3-minute mark, if you could just reach out to your colleagues and ask them to call into the session, that would be very helpful, so we can be able to start the session. And maybe Emma, just to be sure, I hope we have all the panelists on call. Just reach out to be sure that we have everyone logged into the session, so we are sure that we shall have a seamless session. And we appreciate everyone who takes time to call into this session. There are lots of learning that takes place, and we hope that even this particular session will be as helpful to you as the previous session, and I will help you to streamline your approach to patients that walk into your emergency department with similar presentation. Good to have you all. Just quickly tap on that colleague that's not yet on the call, so we can be able to kickstart. Right, I think we shall carry on, and we hope that we shall get the rest of the people called in as we move on with the session. Once again, I'm Jimmy Atiara for those that have just joined in. I will be moderating this session today. I have a team that shall be taking us through the presentation, and I have Evie Barry, if you can just introduce yourself in a minute. Evie?
Yes.
If you can just introduce yourself in 1 second. All right, let's have patients introduce ourselves. Just a short introduction.
Good evening, ladies and gentlemen. My name is Kwagala Persons. I'm a Busitema student. I'm currently joining 5th year. I'm doing medicine and surgery.
Thank you, patients. If you are able to introduce yourself now.
Yeah. My name is Evie Obare. I'm a pre-paramedic officer. I'm awaiting my graduation in December. I'm from Masinde Muliro University in Kenya.
Thank you, Evie. Good to have you. Dr. Nolbert.
Yes, good evening, Jimmy. Good evening, everyone. I'm very happy to be here. Norbert Gumisiriza, psychiatrist and lecturer. Thank you.
All right, thank you. And for those that are on call, you could, if you have any question, you have any comments, you can keep them coming in the chat. There are going to be Dr. Daniel Olinga, who is an EM physician, and will be attending to those questions, as well as Dr. Ankaguna will as well be taking care of your questions in the chat. So feel free to interact with them in the chat as we go along with the case. Let me take this opportunity to welcome Evie to take us through the first segment of the case. Over to you, Evie. Evie, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, I can hear you. Carry on.
Oh, okay. Good evening, everyone. So we are just going to start off the presenting complaint. We have a 26-year-old male who came to the ED with a chief complaint of seeing and feeling insects crawl all over his skin, episodes of uncontrollable shaking of his body, agitation, trembling of his hands, nausea, and vomiting. So on the pre-hospital care part, this is how the situation was handled. The staff comprised of one paramedic and an ambulance operator, who is technically the driver. We had one patient who was currently non-emergent. Some of the equipment or medication that was used were the communication devices, the patient monitor devices for the vital signs, IV fluids, non-consumables, and medications, including analgesics, antipsychotics, and antibiotics. The type of ambulance that was used by the pre-hospital care team to respond to this call was a type B ambulance, which is basically a basic life support ambulance.
All right, thank you so much, Evie, for taking us through that first segment. We are going to have a poll launched to our screen for us to respond to. Kindly respond. The poll has been launched. And the question read, what does the acronym ISBA stand for in clinical communication? Option 1 is introduction, summary, background, action, response. Do you think it stands for option 2 or B is identify, situation, background, assessment, recommendation? Option C is initiate, statement, background, advice. Kindly don't stop the poll. People are still responding to them. Just go on and respond. If you could just relaunch the poll. We have the poll relaunched. It was stopped. Or do you want me to do it? I could do it from my end. All right, the poll has been relaunched. Kindly respond. We shall give it about 2 minutes, and then we carry on with the presentation. This is basically to keep the engagement coming in and also help us to understand where we are at so that we can better deliver the session that is tailored towards your interest. So we know that communication is quite key when handling emergency. A number of times you'll have to maybe transfer a patient from one unit to another, or from one hospital to another, or even from the scene or from their home, and you have to hand them over to the emergency department. And it really helps to have a systematic way of handing over the patient so that you not miss out some of the important aspect of the case, that other patient's presentation, what you've been able to do. And we understand that sometimes the emergency department can be quite tense, and also emergency approach itself can be quite tense. And if you do not have a systematic sort of acronym that guides your communication or guides the way you're going to be approaching the patient, sometimes can be quite challenging. So it's really quite helpful to have a tool that you follow when doing what you want to do for the patient. All right, so we have a response at 67, quite a number haven't yet responded. If we can have everyone respond, then we carry on in 30 seconds, it will be quite helpful. question is quite clear for those that have just joined. Our poll question is, what does acronym ICEBUR stand for in clinical communication? Do you think it's option A? Do you think it's option B, option C, or D? All right. I think we shall carry on. You can end the poll, and then we have Evie take us through the rest of the presentation. Over to you, Evie.
Okay, thank
Evie,
you.
are
So,
right.
can you hear me? Okay.
Yeah, we can hear you now.
Okay. So, the ICEBUR report from the patient that we were called to respond to. We started with identification. We identified the patient and ourselves. And I am Evie, a paramedic dispatched with my team to come and pick the patient. The situation that we found there was that the patient is seeing and feeling insects crawl on his skin and is agitated. On the background, this is a 26-year-old male with history of shaking hands and legs, episodes of vomiting and aggressive behavior as reported by the mother and brother, and this is the second time in 6 months. On assessment, there was mild respiratory distress, there was confusion, irritability, and general body malaise. En route, administered phenobarbital and paracetamol. On the R, which is recommendation, we recommended for monitoring vital signs and for emergency medicine physician review in the ED.
All right, thank you so much, Evie, for taking us through the pre-hospital care of this patient. I will entertain question in maybe 2 minutes. Anyone has a burning question towards the pre-hospital care of this patient, you could raise it up at this time. Any comments that you'd love to make? Evie took us through what was prepared, and then in ICEBUR report, she also took us through how the patient was found, how the patient was moved to the and what was done for the patient, and what they would recommend the emergency department team to do for the patient that they are handing over to. And also feel free to post your question, your comments in the chat. We have Dr. Anna Kaguna and Dr. Olinga Daniel attending to those questions and comments. All right, if there are no questions and there are no comments for Evie to respond to, I'm going to go ahead and invite patients to carry on with the remaining segment of the presentation. Go on, over to you, patients.
Okay, thank you, Dr. Jimmy. I hope I'm loud and clear.
You're loud. Go ahead. Okay.
So on arrival to the emergency department, we had a primary survey conducted on our patient, and these were our findings. For the airway was patent. Our patient could ably talk. He had a respiratory rate of 23 breaths per minute. He was saturating at 94% on room air. There was equal bilateral air entry and no added breath sounds. His pulse rate was 110 beats per minute, a BP of 184/92 millimeters of mercury, and his capillary fill time was 2 seconds. His Glasgow scale was 14/15. Our patient was disoriented. His pupils were equal and reactive to light. We had an random blood sugar done, and we got 6.8 millimoles per liter. He was tremulous, diaphoretic, but there were no traumatic injuries.
All right, thank you, Evie, for taking us through the primary survey of this patient. At this point, I would love to invite Dr. Nolbert to just give us what his initial thoughts And then how should we prepare to approach this patient?
Yes, thank you, Jimmy. And thank you, colleagues, for presenting the case. So this is a case that can be, I don't know, the first thing that comes to mind is someone who is violent. Just imagine someone who is violent, someone who is hallucinating. Hallucination, for those of you who don't know, people see things or hear things or feel things that others don't feel. This is a patient who is having things to move around. So in other words, it's a psychotic patient. That already points to a psychiatric condition. So you think already thinking psychiatry. So from the presentation, the pre-hospital presentation is that when they pick this patient, as Jimmy had already said, there should be some form of stipulated format on which you can approach the patient, and that is usually the first thing I did here was safety. If there was no emphasis on safety or any precautions that were taken in regards to safety, and then because an agitated patient is a patient who is an emergency, meaning he can harm himself, you, or others. The second thing I did not hear about is the first thing of primary survey is the patient okay? You do not so much care about the diagnosis, but the primary your primary concern will be maintenance of that life stabilization, and therefore the ABCDs have to come in. So they did things, but it again, lack of systematic. So the first thing you do is assess the situation, the safetiness of the patient, yourself, then go on and do the ABCD, as I think we all know. The airway, I know they did it in hospital, but even with the airway, the breathing, the circulation, the drugs, okay, or disability, okay, exposure to anything. So that should be the first thing I didn't hear or could have been done better. The other gap I saw was in terms of drug. I think the drug, if I'm to recall right, it was a used barbiturate, phenobarbital, I think. That is not. I would not recommend that. Benzodiazepines are better, so they would have been best served if they had used diazepam, and they stopped there. And that was in regards to the agitation. But remember, the patient also had psychosis. The benzodiazepines or the barbiturate will not take away the psychosis, the hallucinations. So if I'm to recall right, they did not also give an antipsychotic.
I think the part of management is yet to be presented.
No, sure that was primary. Sorry.
Okay.
Those were the gaps. So the primary survey had a problem, and the choice of drugs given had a problem. But the rest, I think, they're on point. Thank you.
Thank you so much, Dr. Nolbert, for that. And also, I see quite a number of engagement in the chat, and keep it up. So let's carry on, questions.
Okay. All right. For our sample history, our patient still presented with feeling and seeing insects moving all over his skin. He was convulsing, had hand tremors, was agitated, and also had a history of nausea and vomiting. There were no known allergies, and he was not on any medications. Regarding his past medical history, this is his second admission in his life, and his first admission was also due to similar signs and symptoms. He had breakfast about 8 hours prior to admission, and the events leading to this presentation, the mother reported that he just suddenly became agitated, diaphoretic, and tremulous.
Right, thank you, Patience. And we would want to turn back to the audience and just let us know, is there any additional information that if you are taking care of this patient, you would really be very interested in knowing particular things that you would, questions that you'd be asking about this patient? Henrietta, is there any particular question that would come to mind if you had this patient in your ward? Something that something that you think should be very pertinent in helping you to manage this patient. Someone was asking, was there any history of substance abuse? All right, I think that will be answered. Dr. Patricia, any particular question that would come to mind? Patricia Donna Bukali. Henrietta would ask any medication that the patient is currently taking. I think that was answered in the sample history. There were no medication that the patient was routinely taking at home. Jethro is asking any history of trauma in this patient. Someone was asking, Sarah Orinawa is asking, was there any history of substance abuse in this patient? I think those are great thoughts. Great thoughts. Pasco is asking, was there any history of any history of fevers, and how many times did the patient convulse? All right, I think those are great thoughts. I'm very sure that all these questions will be answered as we carry on with the case. All right, I think let's move to the next segment of the presentation. Dr. Nolbert, after listening to the sample history of this patient, I know you've already given quite a number of thoughts in the first time when you got to hear about the history of this patient and the primary survey. I'm just wondering whether there are some additional thoughts that has come to mind after listening to the primary survey of the sample history of this patient in particular.
Yes, thank you, Jimmy. And when I look through the questions that the participants are giving, and I am rather happy to say that people are now, I think we are having the same thoughts, we're thinking in the same direction. Secondary survey essentially is when you have already stabilized the patient and you're trying to now find out what is going on, what caused the initial issue. And this necessitates you to be more comprehensive. So history, examination, and investigations, of course. So the signs and symptoms will point to a certain direction, and you're already seeing hyperactivity of the CNS. And what would cause the hyperactivity of the CNS? Probably a substance, a disease. Okay, so that's where your thought should be, and maybe some medical condition. So substances, if you're looking for substances, it is substances that are stimulants. Talking about your cocaine, methamphetamines, or you're withdrawing from a substance that is a depressant. So you're withdrawing from alcohol, you're withdrawing from benzodiazepines. So it is very important to take history of substance use, if there's any dependency, therefore you can think of a withdrawal. Medical background, do they have any chronic illnesses, epilepsy, liver disease, HIV, are they taking any medications? Okay, so you want to rule out all those things. Then of course, this is the second time it has happened. Was it a primary psychiatric condition, perhaps? Okay. You also want to look at the social context, the circumstances surrounding this very time. He's representing complaint. Maybe there was circumstances in their life that was happening. Maybe he lost a job, family lost. Okay. So this is, and most of it, unfortunately, you will not get from the patient, although he was a bit stable. So this is the time you probably do more collateral history to fill in those gaps. In terms of examination, please do head to toe, the CNS, your CVC, cardiovascular, okay? And then, of course, investigation. I don't know if we're going to have investigations to be done, but your investigations in essence, your investigations with either rule in or rule out whatever you're thinking. By the time you get to investigation, you've already formulated 3 or 4 differential diagnoses. Thank you. I don't know
Thank you
if
so much. Yeah, that was really, really, really helpful in guiding us to contextualize and understand this case. And I really appreciate your expertise, Dr. Norbert. All right, I think we're going to carry on with the rest of the presentation. Keep your questions coming, keep your comments coming in the chat. We'll be sure to get them attended to. Over to you, patient.
Okay. So after we received the patient, this is how we managed in the emergency department. We admitted the patient to the mental health unit. We administered 20 milligrams of diazepam IV. We also administered 200 milligrams of chlorpromazine IM. We administered thiamine 50 milligrams with multivitamins and also gave IV fluids. We gave normal saline, about 500 mils. For the secondary survey, after patient was a bit stable, on general exam, there was a moderate dehydration. However, there was no pallor, there was no cyanosis, there was no finger clapping, there was no lymphadenopathy. The other systemic examinations were unremarkable. So we went forth to do a mental status examination. So our patient was disoriented with hand tremors. He was having hallucinations. His speech was slow and slurred. He was in an angry mood and very irritable affect and had no insight. However, his memory and judgment were intact. So we had some investigations done, and these were the results. We had liver function tests done, and we had total bilirubin of 17.7, direct bilirubin of 9.7, aspartate aminotransferase of 38.4, alanine aminotransferase of 42.2, a GGT of 55, and alkaline phosphatase of 131. We also had a complete blood count done, and his white blood cell count was 12.34. He had a hemoglobin level of 12.4 and a platelet count of 161. We also had serum electrolyte panel done, and his sodium was 128 milliequivalents per liter, and potassium was 3 milliequivalents per liter. We also went ahead to do some psychological screening tests. We used CIWA, which is Clinical Institute Withdrawal Assessment for Alcohol, revised, and also we used AUDIT, which is Alcohol Use Disorder Identification Test. And the results are as follows. For CIWA, we had a 39 out of 67 score, and for AUDIT, we had a 17 over 40.
Perfect. Thank you, Patience, for taking us through those other segments of the presentation. We're going to have a poll launched on your screen. Kindly respond to the poll. We won't take about 2 minutes to respond to the poll that is just about to be launched to your screen. This is to help us continue to engage with you and get to know how well you are following the case. We already had about the history of this patient. We had the presentation on the primary survey. We've had the sample history. We've had the lab results of this patient. And we've heard about the secondary survey as well. So at this point, we would love to know from all that we have had so far, what is the most likely cause of this patient's presentation? We're going to take up 2 minutes just to have your responses come in. What do you think caused the patient to be brought to the emergency department? And as we do that, you can still keep your comments coming into the chat. Questions, if you have any question regarding any particular aspect that has already been presented, keep them coming in the chat. We shall be sure to respond to those questions as they come in. And I also know that we get quite a number of these cases actually in the emergency department, and sometimes can be very challenging, especially for finds you with so many patients and you are not having quite a settled mind to actually explore some of these aspects that are being presented for you to be able to arrive to a potential cause of their presentation in the emergency department. And this is why we think that this presentation are really helpful for us to navigate similar patients when they present to us in the emergency department. What should we do? Dr. Nolbert has already guided that as you approach this patient, these are patients that are potentially agitated and might be violent. So you have to be sure that you are safe, even as you approach the patient. You want to get the right medication within the shortest time so that you can be able to stabilize them to allow for you to explore some of the other aspects of the patient. The history, your examination findings could be very helpful in turning your thoughts towards a particular direction. We still have 27 people out of 67 responding. So if you can keep your answers coming, would be very helpful. We're having about 15 seconds to end this poll, then we can carry on with the presentation. All right. And thank you, Dr. Nolbert. I think the guidance has been really great. I can see the responses that are coming in. Been very helpful. All right. I think we shall go ahead and end the poll so that we can proceed with the rest of the presentation. Questions? I think we can move on to the next slide. All right. At this point, maybe before we call on the expert, I would just want to give opportunity to 1 or 2 people to just give their thoughts on what their potential differentials could be. I know that there was a poll that was launched, but maybe that's not the total sum of the differentials that you might be thinking about concerning this patient's presentation. You could just raise your hand up. We'll be able to identify you and give you an opportunity to speak. anyone that would love to give us what they are thinking about in regards to this patient? What we've so far had concerning his history, ICBAR report that we received from the pre-hospital care team, and the primary survey that we've done, secondary survey, the initial approach, and then we've been able to explore about the lab tests that this patient had. Anything that comes to mind in regards to differentials that we're thinking about. Eric Mwesigwa, what would you be thinking? What would be on the list of your differential for this patient? Well, I think today people are shy to speak. This is a learning platform, and we are all here to learn. So just feel free to interact. The more we engage is the more we learn. Maybe I could call on Crispus Nkoyoyo. What would be on the list of your differential for this patient? You can just go on and unmute and tell us what you think. Oh, the room is so quiet. All right, maybe let me give a chance to David. David Bulega. You could just unmute and tell us your thoughts in regards to the potential differentials that you're thinking. David Buyinza, sorry. Patricia, what would be on your list? I've seen Henrietta has posted something in the chat. Would you just want to give us your evidence to support that could just help us to understand where you're coming from? Henrietta, do you have to unmute? All right, I think we shall carry on. Unable to speak, okay. Henrietta is unable to speak. Sarah, Warinawe, what would be on the list of your differential for this patient? If you have any space at all to speak. All right, I'm going to call on Dr. Nolbert to guide the discussion on the potential list of differentials as well as how we would approach them as we manage them in the emergency department. Over to Dr. Nolbert.
Well, thank you, Jimmy. Maybe when I'm lecturing and there's a case during maybe ward round and students don't know, the quickest trick you can use is don't mind about the diagnosis. The first thing you do is list the problem, make a problem list. And then if you try to bring together the problems, you'll actually see patterns emerging. And this is probably, let's go through this. You must know that I was also blind to this case, so I am also jotting down as I'm reading. So the problem I'm seeing from the primary survey, the patient has had agitation, was hallucinating, irritable. Okay, so you're already seeing some sort of psychosis. Then we saw the patient had some tremors, diaphoretic, hypertensive, some form of autonomic hyperactivity. Okay, so those are two. What do I call? From the history, remember, this is not the first time. It's the second episode, if I'm to remember. And tremors, of course. So you're already seeing a pattern of tremors, your autonomic nervous system, hallucination, psychosis. So what are some of the differentials you can think about? Okay. You think of a primary psychiatric condition that has these. Probably you're thinking of schizophrenia, think of bipolar mania. Okay. That is on one side. Could it be something organic, something medical? Because an infection can, meningitis, even cerebral malaria can cause it. But remember, if I'm to recall right, you can correct me if I'm wrong, Jimmy, I don't see any fevers. I think the CBC was normal.
Yeah.
Okay.
Yeah, absolutely. Yeah, you're right.
Yes. So then you see now you rule out, or you try to rule out an organic cause, at least for now, until maybe the other results come in. What of trauma? I also don't recall any history of trauma, especially to the head, because this can also be a cause. So you rule out trauma. Could it be maybe the neck was soft, so you're ruling out all those meningitis? So it leaves the most likely diagnosis to be, and if you add the labs, we are looking at the liver function tests. We're looking, remember they did audit. It's a tool that we use for alcohol. It pointed to harmful drinking. So you were thinking this is someone who takes alcohol, okay, at least for now, with psychotic features and autonomic hyperactivity with tremors. So could it be substance-induced psychosis? Okay, the psychosis is directly causing it. Okay, or could it be a withdrawal? Okay, that would best be answered if you took a more comprehensive history to find the chronology of events. What happened during the time this patient has these symptoms? Was he drinking, or he had spent some time without drinking? Okay, that can usually point you to a direction. Then you have this this very particular symptoms of disorientation. Now, disorientation, for those of you who don't know, it's a neurocognitive symptom. Disorientation, and the easiest way, and it's something simple, just ask the patient, how are you? What's your name? Where are you? What time is it? They're disoriented in time, place, and person. So if there is any problem with that, that is neurocognitive, okay? Meaning that it's something to do with cognition. And from the hierarchy of disorders in mental health, you now think of a delirious or dementia, you're pointing that direction. It takes precedence over psychosis. I hope I'm not confusing you. So if you add up this delirium, rather disorientation, autonomic hyperactivity, the tremors, okay, with the history of recurrent alcohol use, we're already seeing the alcohol is bringing problems to the liver. That makes the most likely diagnosis to be alcohol withdrawal, okay, delirium, delirium tremens, in other words, okay, with maybe a differential. Always put a differential of maybe substance induced, okay. Another differential would be some substances, stimulant, like amphetamines, cocaine, cat, which you call Mairunj. So a substance that stimulates can cause this picture, okay? But if you're also withdrawing from a depressant, it can stimulate the brain. It gives an opposite reaction. So according to this, the most likely diagnosis is alcohol withdrawal, delirium tremens. But that is half the story, because this will again go into the long-term management. You can only get alcohol withdrawal if you are a dependent, if you have a chronic history, or for lack of a better word, if you're alcoholic. So the more comprehensive diagnosis is actually a chronic alcohol user with an acute effect of withdrawal. So it is alcohol use disorder with alcohol withdrawal delirium or delirium tremens. Now that is one, but with if you want to be a more comprehensive doctor, then you'll also add the liver issue. Now we're also having problems with the liver. So you probably give maybe chronic liver disease. I don't know how the exact diagnosis. And the reason I insist on putting all these as opposed to one diagnosis is that we tend to treat one and forget the others. So, but if you write all your problems, even if you do not come to a conclusive diagnosis, you can start from there by eliminating the problems. But if you can make a diagnosis, you also make it as comprehensive as possible, so that you know that after you manage this acute phase of delirium, there is the other bigger thing of dependency, which actually brought the whole problem. Then there is also the physical thing of the liver, which also needs to be. So you have to treat the patient holistically. I think that for now, that is all, Jimmy.
Thank you so much. And I think that is very good guidance. I love the fact that he said sometimes in the emergency department is not about diagnosis, but about being able to save the patient, stabilize them, then you can be able to explore the rest of the possibilities later as we go along with the care of the patient. Thank you. I think that guidance was quite helpful. Let's carry on. Patients, over to you.
Thank you, Dr. Jimmy. Thank you, Dr. Nolbert. So, in line with what Dr. Nolbert was thinking, our working diagnosis was alcohol withdrawal syndrome. So we have to note that yes, our patient is actually a dependent on alcohol. He has a history of daily consumption of alcohol. He takes about 5 beers per day. And prior to this presentation, there was sudden cessation of alcohol. And then he presented like this. So we came up with the following differentials. We have alcohol-induced psychosis, alcohol-induced anxiety disorder, could be a hypoglycemia, an essential tremor, or other substance withdrawal, for example, the sedatives, hypnotics, or anxiolytic withdrawal. In the mental health unit, I think for about the next 2 days, the patient was admitted. He was managed as follows. We use the biopsychosocial model. So for the short-term management and the long-term management, for the biological management, we continued the patient on diazepam and thiamine, and we tapered accordingly. Long-term, the patient was given naltrexone to curb the cravings, and we continued with the maintenance therapy of the benzodiazepines. For the psychological management, there was psychoeducation of both the patient and the caretakers, motivational interviewing therapy, systems and cognitive behavior therapy. And for the long-term management, patient was advised to continue with the psychotherapy. For the social management, we mobilized for social support, especially from his family members and relatives. Then the patient was also advised to join peer support groups, particularly there's a church group that he attends. So that was the management of our patient.
All right, we have a poll that's going to be launched, and I would kindly ask that we respond to it quickly, so that we can keep track of our time. We are going to give ourselves 1 minute to respond to this poll that has already been launched on your screen. We've gotten to know about what the thoughts were in the emergency department regarding this patient's presentation and possibilities of the differentials. And now we want to avoid further deterioration in this patient. And as Dr. Gumisila guided, that we need to come up with a list of problems for our patient so that we can be able to address the problem, stabilize the patient, and then so that you can have time to explore with the rest of the aspects of the clinical care of this patient. And not only addressing one problem, you need to exhaustively think about possibilities that this patient could be having, getting your labs and tying them together with the clinical arguments will go a long way in ensuring that you give the patient a comprehensive and holistic care for a better prognosis. So we have a poll launched in 30 seconds. We shall be ending the poll so that we can proceed with the rest of the presentation. Just go ahead, keep your responses coming. This is basically to help us know that we are keeping track with the case as it's being presented. We are all together following the discussion as we go along. All right, I think we shall end this poll and then we continue with the rest of the presentation. Over to you, patient.
So for our take-home message from today, we're dealing with alcohol withdrawal syndrome. So basically, we're just going to figure out how it's diagnosed and how these people present the different stages of the alcohol withdrawal syndrome. So we use DSM-5 text revised. So to diagnose alcohol withdrawal syndrome, it should be based on the following criteria. Criterion A, there should be cessation of or reduction in alcohol use that has been heavy and prolonged. Criterion B, it should be 2 or more of the following depending within several hours to a few days after cessation or reduction in alcohol use as described in criterion A. The symptoms, the 2 or more, should be either autonomic hyperactivity, an increased hand tremor, insomnia, nausea or vomiting, transient visual, tactile or auditory hallucinations or illusions, psychomotor agitation, anxiety, and generalized tonic-clonic seizures. Next, please. So in addition to criterion B, for criterion C, the signs or symptoms that we have seen in criterion B should cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And for criterion D, the signs or symptoms that we saw in criterion B should not be attributable to any other medical condition and not better explained by another mental disorder, including intoxication or withdrawal from another substance. So for the alcohol withdrawal symptoms, there are about 4 stages, and I tried to summarize them. So for the first one, we could have a minor withdrawal, which usually happens 6 to 36 hours from the last drink. Usually there's a normal mental status, and then the patient could present with tremors, a mild anxiety, headache, diaphoresis, palpitations, anorexia, a GI upset, and insomnia. Then the person could present with seizures, and this could be 6 to 48 hours from the last drink, or sometimes as early as 2 hours from the last drink. and they're usually generalized tonic-clonic seizures. They could be singular or maybe series of seizures over a short period of time. And if untreated, a third of these cases usually progress to delirium tremens. Then we could have hallucinations, which occur 12 to 48 hours from the last drink. Also, a patient may have a normal mental status with normal vital signs. And the hallucinations are usually visual, but they can be auditory or tactile, but they usually resolve in less than 48 hours. Then lastly, we have delirium tremens, which usually occurs 48 hours to 96 hours from the last drink, and the patient presents with disorientation, agitation, hallucinations with increased autonomic activity. And it could last 5 to 7 days, and there's usually a 5% mortality rate. Yes, thank you. That's what I had.
All right, thank you so much, Patience. I will invite Dr. Nolbert to give us his pulse and pitfalls of the case. What should we take home from this case, and what should be the emphasis when handling patients who come to the emergency department with similar presentation? You'll do that in about 3 minutes or 2, and then we can have the session and come to an end. Over to Dr. Nolbert.
Hey, thank you, Jimmy. The management has been ably, the diagnosis and management has been ably presented by my colleague. Maybe the take-home message, I would say, although you see, the topic today is psychiatric emergencies, but you have to understand that any psychiatric emergency is actually a medical emergency first, okay? So before you think of or categorize it in any way, the fundamental principles remain the same, okay? So therefore, do not forget your A, B, C, D, E, okay? Some people even add F, okay? And I'm sure you will study them. This is not a time or the forum, okay? So preparation is key in terms of knowledge, in terms of skill, your CPR. So you always be ready. You don't wait for an emergency to occur to learn, okay? Then in terms of maybe, I don't know if there are hospital persons here, emergency places should be ready, or even ambulances. You should be having the equipment, the drugs, okay? On top of the knowledge, you also have to have equipment ready, okay? Like an emergency trolley or with antidotes, with fluids, benzodiazepines, and all those things, okay? Safety, 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 okay? Always be safe. We don't want heroes. Okay, we want always think of ourselves as heroes, but I would rather be a coward and live to tell my story than you guys writing nice messages about me after a patient stabs me. Okay, so safety first, and do not be afraid to call for help. Call whoever, askari, call the attendant. If in an event that you think this patient is very agitated, okay? So, which means you must do a rapid assessment in terms of safety, even before you attach the patient. Okay, what is this? Can I handle it? Can I defer? Can I call for police? Okay. Then after doing, remember ABCD is for, is there life? How can I maintain this life as we move on to the next stage? Maybe if you call for help, because sometimes people call for help and I'm consulted, and then I find the consulting person is seated in the nursing room waiting for me. Then I ask, what have you done? I'm waiting for you. Even if you call for help, please do something as you're waiting for help. Do not sit back and relax. Okay? So this is where I would say there is something you can do about it. So do not do not feel bad that you have not figured out what is causing the problem. If you do the fundamentals, you will at least sustain life until someone more senior comes in. Now, when it comes to specific to psychiatry, there are quite a number of psychiatric emergencies. The list is endless, okay? But I would say there is tendency of persons to push anything into psychiatric ward, just like this patient. In reality, this patient should be an emergency ward because they are best suited to or managed in an emergency ward, even internal medicine, before they are brought to psychiatry. Many of the patients that die in psychiatry are actually medical cases or psychiatric cases with a component of medicine. Not that we don't know our okay, partly because we are tunnel-minded. You know, people when they're obstetrics or surgical or psychiatry, we tend to super specialize. But in this case, it should be the best place should actually have been a medical ward because the patient conditions that are going to kill the patients are more medical than psychiatric. Okay. And then we can have collaboration. So there's no need to ping pong, toss around the patient, stabilize the patient. Then when it's stable, move to them to the psychiatric ward. Particularly for this case, delirium tremens is very common because, you know, as Ugandans, we are the #1 consumers of alcohol in Africa and number about 3 or 4 in the world. So you are most definitely going to see a lot of these cases. And some of you probably have suffered from this in terms of intoxication is more common, but now we are seeing a lot of more withdrawal. Okay. The issue of the delirium tremens is it is actually much worse. It's one of the most dangerous emergencies we have in psychiatry. It's life-threatening. So you have to be very fast making decisions, or at least call for help, and managers have ably told you how to manage. And then when you stabilize the patient, please do not forget that this is an acute on chronic illness. Because it's the second time, the chances of relapse are going to are very high. Okay, therefore, do not simply stabilize and then let the patient go. There has to be a full comprehensive addressing the primary cause, and the primary cause is the use of alcohol. So they have to go into psychosocial rehabilitation throughout the whole thing. I think essentially that is it.
Thank you so much, Dr. Nolbert. I've always looked forward to listen to you speak mental health and psychiatry, and we could not have had a better expert than you for this particular session. And we really want to thank you so much. Emma, if you could just display the wall of fame. I really want to thank you so much for investing in us the knowledge, taking time off your busy schedule to walk us through this case. I'm very sure that there's been a lot of learning, and I looked through the chat and I could only imagine how much people have learned from this session. We want to, when we were beginning the session, I said this is our 9th session, and you can see that we've had quite a number of sessions, and we have these sessions recorded. You can visit our YouTube channel, you can visit our website, and you can find the session materials uploaded for you to be able to interact with them and refresh your knowledge. And again, we cannot be thankful enough to the team that takes time to prepare and put these sessions together for us. And in a special way, we want to thank patients, we want to thank Evie, who have taken time to prepare for this session. It's been quite a number of meetings and getting things put together. And we also thank the Secretariat that takes time to guide the formulation of the case, and then ensuring that the case suits the interest of the audience. We're going to share a survey for you to give us your response, your evaluation of the session, so that we can tailor the session to best suit your needs. Dr. Norbert, we really look forward to having you again in such a forum. Learning from you has never left us the same. All right,
Always a pleasure.
Manuel, you can go ahead. Emma, over to you.
Thank you all very much for joining in our August CPC session. This is our 9th session overall. Next month, we shall be making the 10th session. We are very glad to have you joining in every month, taking time. We know that usually our sessions happen late in the evening or Friday evening when everyone is tired, but we are very glad that you keep on taking time. And for the repeat attendees, we usually want to do an annual certification and try to give back to some of the return participants. In this case, we will try to award them with a bit of certificates. So keep on coming in for the sessions, keep on coming back. We have currently launched our post-test. You can just go through the post-test, and this is just to ensure that we have had we have learned a lot from the session. It's the one way we try to evaluate our sessions as well. We shall be rolling out an evaluation form, probably through the emails and through the different platforms, such that you can give us feedback on the sessions that we have and how we can best organize and prepare for the ones coming up ahead. We thank you all so much for your continuing support and attendance for our sessions. So, also attached in the chat, we have our Twitter or the new X, our website where we find the resources for all these sessions, and then you can follow all these sessions in case you joined in late on our YouTube site as well. Thank you so much. Keep on filling the post-test, and as we can thank also our experts. Thank you very much, Patience Kwagala, Ivio Barre, and Dr. Gumesiris Norbert. It has been a pleasure working with you. We hope to have you back for future sessions. CPC, we still keep on improving with our aim and our goal, and our theme usually is mastering emergency care. Yes, thank you so much. For me, I'm very grateful for the continuous attendance. Unless anyone else from the Secretariat has something to say, but thank you and have a good night.